Hello guys, can you hear me? Can you see me? If yes, give me a signal of thumbs up or say something. Welcome back to the YouTube channel of Unacademy. So the FMG exam results are out and we are excited to have amazing results this time, and we'll be sharing the strategy of what the students did the past time and how Unacademy as a team was able to provide them a little bit of support in their successful journey, right? And the FMG focus batch is going to start recently. If any of your friends are a foreign graduate, they can come. The one advantage here is we have live sessions and you can have interactions compared as opposed to others, right? There are a few codes. If you want any code, you can use any discount coupon for you to go ahead with that. And if you don't have anything, you can use Pathocups, right? I'm more than welcome for it. Okay. So what we'll be discussing today is, today's topic was supposed to be GIT and renal. So I thought that we will discuss in depth about the topic of GIT, colonic cancer. I'm sure you guys know lots about colonic cancer. You must have known about lots of syndrome. You must have known about right side colonic cancer, left side colonic cancer. My purpose here is to read the same thing, but in a different way. We'll try to understand the disease. We'll know that why a particular mutation is more prone for right side cancer, why a particular mutation is more prone for left side cancer as well. There are nuances in each and everything of that, right? So we'll be reading all of them along with totally a new approach of colon cancer, right? So today's, if time permits, we might take up a little bit of renal as well. Don't worry, we are going to have much more YouTube sessions in next month, upcoming month, and we'll be discussing everything as well. Okay, great. So now let's start with today's topic. We are going to discuss a little bit about colonic carcinoma, and do not miss today's evening 8 o'clock class. There's going to be a class on your 20 MCQs on GIT, the intestine part of GIT, fine, and we look forward to your active participation in that as well. Okay, so when you go to colonic cancers, any cancer for that instance is going to have two types of etiopathogenesis. I'm going to have an inherited type as well as I'm going to have like an acquired type of a cancer, right? That's the same thing holds true for colonic cancer as well. Colonic cancer also has your inherited types and your sporadic types of cancer, right? So pathogenesis for both is going to be totally different, inherited as well as sporadic, right? Inherited, I'm sure that you know few mutations. Name a few mutations in inherited cancer which you are aware of. Then maybe we'll go to something new, if at all, if there is anything new, right? The inherited mutations, the famous one is your APC pathway in your familial adenomatous polyposis and your HNPCC, right? Hereditary non-polyposis colon cancer, your MSH genes, perfect, right? So we'll go with sporadic cancers first. When you take sporadic cancers, if you looked at almost every textbook I'm going to look for sporadic etiology of cancers, especially colon cancers, they attribute more of them to food, right? They attribute more of them to food. Food is one of the important things because colon, see, when I'm going to have skin gets exposed to various carcinogens, right, in the form of chemicals. Whatever we apply is also carcinogen. Here it's going to be predominantly diet and food, right? Because colon is not going to expose to anything. Colon is going to expose majorly through carcinogens, which goes via your oral cavity, which we ingest, right, knowingly or unknowingly. So when you look at the food, there are few things which will promote the cause of promote the pathogens of colon cancer. Few of them which are going to reduce the effect of colon cancer. We'll look at something positive first. Which of them are going to get reduced, right? Which of them reduce the incidence of colon cancer, or which of them are protective? The protective things are green vegetables, anything with a high fiber diet, right? Anything with a high fiber diet is going to much more protective. All of us should include this in your diet. We generally don't like greens. We generally don't eat anything which has high fiber content. The concept is very, very simple. Anything when I'm going to have high fiber content, what it is going to do to the bowel movement? It will increase the bowel movement or it will decrease the bowel movement. The answer entirely lies on that, right? When I have anything with a high fiber content, obviously my bowel movement increases. When my bowel movement increases, let's assume that I have a carcinogen itself. The duration of stay of the carcinogen in the colon will be reduced. Once it's reduced, I don't have much reaction, give time for it to react and cause DNA damage. So I'm just flushing it out. I have carcinogen, It came, it got flushed out, right? So these are going to increase my bowel habits, bowel movements. Once they increase your bowel movements, automatically what's going to happen is it's going to decrease the transit time, or it's going to decrease the exposure time of any carcinogens whatever we have. Okay, exposure time of carcinogens. Okay, that's one major aspect. All of us should have high fiber content. Banana, a single banana a day. How many of you have still banana a day? My mom and dad, without fail, they used to have banana a day, because that has been ingrained into their habit by my grandmothers and grandfathers. But for us, having banana is like, it has become like a status symbol, right? Banana a day. No, I don't have banana, right? So it has become like a status symbol that we look down at bananas and very down food. A single banana a day is like, it's like an immunity for a your colonic cancer, right? If you're having it, please do continue it. If you're not having it, start it. It will set right many important things. One single banana a day. Any type of banana, big or small, doesn't matter. One banana a day is enough, right? And try to introduce as much as high fiber diet. Which of them are not, it's going to be causative for same food which are going to be causative for your colon cancer? Lots of them. All the junk we eat is contributory. Carbohydrates, someone said, carbs are one of the major things. Red meat, carbs, excess carbs, right? It's not the body thing alone. Excess carbohydrates is definitely going to be detrimental. It's going to cause something abnormal in my metabolism, which also might increase the risk of colon cancer. The main thing here is red meat, right? Indians as such do not consume red meat much, right? So again, I like the story very much. Your whatever the way we have our medical system structured is from the ancient thing. We already had a system of Ayurveda, right? Ayurveda, Unani, Siddha, whatever it is. See, I'm not promoting Ayush, but at the same time, we have to understand that Ayush has had an amazing foundation to our medical system, because we as a country has been there for many years, right? Many centuries. Allopathic system came new after the foreign invasion, to be specific. Allopathic system is just maybe 100 years old. Before that, we had Ayurvedic system only, right? I don't promote Ayush. But if my government wants to promote Ayush, they have to set up research for Ayush rather than pushing them into allopathy, right? Mixing is not correct. If you want to promote Ayush, please promote that scientifically. We also will be open to that. Every graduate is going to be open to that. Ideally, an Ayurvedic person also will want that only. But our government wants to make a mixture of everything. Divide and rule is one policy they have learned from the foreigners, and they are perfectly doing it, right? So our Ayush system said that food is medicine. I'm sure most of your parents would have at least told this once in your lifetime. Food is medicine. Food is exactly medicine, right? Red meat. We don't have red meat. We don't eat red meats. If you look at our incidence of colonic cancer, it was not high. It was high in the past. Again, go to the National Cancer Registry. Look at the incidence of colonic cancer. It has become so much high in the past 3-4 decades. That's all. Before that, our incidence of colon cancer was very less because of our eating habit, because food is medicine. Last few decades, it just skyrocketed. Same last few decades, surgical gastroenterology and medical gastroenterology skyrocketed. Healthcare, at the end of the day, we may like it, we may want to say it's a service. Healthcare is one of the biggest business, right? Everything goes parallel. When there is a demand, there is a supply. There's a demand for colonic cancer surgeons. There is a supply by the government in the form of surgical gastroenterologists, and you have multiple corporate hospitals doing the same itself. Right? We'll leave the economics of medicine aside for a part. Right? When you have red meat, we don't call chicken and mutton as red meat, right? Red meat is going to be beef and pork, right? Beef and pork is a red meat. Chicken and mutton is not red meat, right? So the reason why beef and pork, it's less in our country, except for few pockets of our country. I'm not saying that we don't consume it at all. We don't consume it on a regular basis, right? Except few pockets. Where do you think beef and pork is common in our country? There are very few pockets in our country where beef and pork is kind of consumed on a daily basis, right? There are only two places which at least I am aware of, Kerala and Northeast. These are the places where beef and pork are consumed like a daily basis, like a foreigner. Foreigners use this on a daily basis. For them, bacon is like food. Bacon is like the food for them, right? So we don't use that apart from these two areas, right? Apart from these two areas, northeastern side, yes, they do consume lots of red meat. and also down south, Kerala consumes lots of red meat. Rest of the country, chicken and mutton is much more common, right? We'll keep this aside and we'll come to reason why that's also important. So once you consume beef and pork, one, I'm going to have carbohydrates more, like saturated carbohydrates more. It'll have lots of energy, and the most important thing here is going to be our vitamin B12. This person is a trouble. This person is the biggest troublemaker. Right? This person is a very, very big troublemaker. Vitamin B12 in red meat, though it is not researched much, right? Though it's not researched much, it's a huge troublemaker, right? When you have lots of vitamin B12, tell me, see, I am not saying that I'm not having it on a regular basis. When you have once in a while, no problem. Daily having it again and again, I'm going to have excess exposure to this. The purpose of vitamin B12 is going to be proliferation. You must have read about vitamin B12 in your bone marrow, right? When you don't have it, we have megaloblastic anemia, which is going to suppress your erythropoiesis. That's why we have your pancytopenia and everything. So we give it in order to proliferate it. So it can cause proliferation of your bone marrow. When it can cause proliferation of the bone marrow, it can cause proliferation of any stem cell. The purpose is going to increase proliferation of every stem cell. Okay? It's going to be increased proliferation of stem cells. Right? So when it's going to be increased proliferation of stem cells, I'm giving it for megaloblastic anemia as treatment. I'm happy with it because I'm getting whatever returns I wanted. Anemia gets corrected, thrombocytopenia and your leukopenia gets corrected. But if I'm going to give it forever, again and again and again, let's say for 10 years, 20 years, I do have a risk of cancer. I'm not saying it will cause cancer, it's relative risk, right? So this, if it is persistent, if it's on a daily basis, I'm going to be worried. Right? If it's persistent on a daily basis, it might slightly increase the risk of cancer. Okay? It might slightly increase the risk of cancer. This is one thing. Okay? This is one thing, it might slightly increase the risk of cancer. So this is problematic for me. Right? Ideally, Indian diet is not having beef and pork, not because of a religious belief. Right? I don't believe in religion, kind of inclined towards atheism. Religion is for me something made by human beings for our own comfort. I don't eat beef and pork, red meat predominantly, for the simple reason that here this is not required for our body. I don't require more B12, I don't require more carbs, because someone said about thermogenesis. This is required in places which has extremes of temperature. India doesn't have extremes of temperature, right? India is like not even in some places, yes, zero it goes, but never in minus. If it goes in minus, it comes in NDTV and in your Republic channel. So that's how rare it is, right? So this is particularly there in colder climates. Right? Except for these two places in India, rest we don't use it because I don't require that much. If you eat beef and pork on a daily basis, you will feel warm. If you've done it, if you've had any time, you will feel warm. Right? Crabs, you will feel warm. Those are not our regular food at all. Right? It's common in these two places only. It's generally for colder climates. And if you've been to any foreign countries where we have beef and pork regularly, right? Any European countries, bacon and beef is very, very common. Right? McD has bacon. Almost everywhere it's going to be bacon, right? Bacon is pig. So when you go to any foreign countries, their food item intrinsically has salad. Salad is part and parcel of everything they eat. They think they're putting lettuce and putting some greens, it's a dish for them. For us, it's something not to look in a buffet system, right? How many of you eat salads in a buffet system? We never go into it. We don't even look in that side, right? So for us, it's something unwanted. So this again is a balance. Mankind has evolved over millions of years, right? So we have read about everything. We modify not only our genes, we are amazing people in adapting to circumstances. Best example, whether it's NEET PG or INI-CET or next PG, 1 month is enough for us to adapt. So this adaptation came for millions of years. They know that, okay, this population is having more beef and pork, so I need to flush them out because some good person scientifically or by experience has thought that excess of beef and pork is causing some symptoms for that person, right? It's like a premonition, right? Some symptoms here. So what I'm going to do is this will flush them out. Flushes the excess B12 out in the GIT, because in GIT I don't want excess proliferation. But yes, at the same time, just for our example, bone marrow will get more B12 anyway, because it's going to get absorbed, it will go to the bone marrow, it will get more B12, right? It will definitely get more B12. So when you take an European person, tell me what will be the hemoglobin of an European person, higher than us or lower than us? A European person hemoglobin, definitely higher than us, right? The build of a European person, definitely higher than us. For us, let's say that we will have an average build of 6 foot itself is for us, okay, on the above person there. For them, 6 is normal. That's why we have all the basketball players on that side, right? We don't have it much. They are well built. Kyle Jamison, example, how tall he is. Look at Prithvi Shah. That's how drastic it is. Our build, our hemoglobin, everything is based on your vitamin B12. So that's the reason their food habit changes. That's why the persons are well built, their hemoglobin is more, and there are a few other reasons as well. Fine. So this is what vitamin B12 does. So now we'll come to our own locality of Kerala and Northeast. How many of you been to Northeast? Any place in Northeast? At least for a tour, trip, any place in Northeast? Or both Kerala as well as Northeast. If you've been to Kerala and Northeast, these two places, especially in a country, the amount of greenery is much more. You stay in Assam, great. You're going to give us more inputs, right? You stay in Assam, so you're going to give us more inputs, right? Subramista, okay? You're going to give us more inputs. Your food habit, does it have fruits more in excess? I'm not saying the hotels of Assam, the traditional habits of Assam. Little bit more greens. Banana grows there well. Lots of fruits grows there well. Kerala as well. Kerala is the largest exporter of banana, right? Banana, the banana products. The banana chips, which has been famous, it's there all over the world. Because these two places, maybe it's a natural adaptation. These two places, I'm not sure, I have to go back in history to understand this, whether the greens was there initially or after people started eating the red meat, greens changed over the due course. Whether the people, the great grandfathers of us, as in your Kerala and Assam, they cultivated more greens, they want to have more greens because they know that the food habit is like this. Kerala and Assam is where bananas and greens are in lots. When you come to Tamil Nadu, I have only one thing, which is spice. Spice and biryani is the biggest thing there, right? So again, I have a perfect balance. When there's a perfect balance, food is medicine. I didn't have any problem, right? This is about normal perfect balance of food. Now let's assume what will happen when we disturb the balance. That's a problem. When we disturb any natural order, we are going to have trouble. Whether it be natural calamity or our body's natural calamity. Disturbing the balance is sitting in the mid of Andhra Pradesh and having lots of beef and pork on a regular basis. Right? Lots of beef and pork on a regular basis. Problematic. Looking at KFC advertisement and going to some exotic shops and having pork and bacon and again abnormal things. On a regular basis, having excess of your carbs, abnormal, right? Our diet habit changes. Okay? When a diet habit changes, if we are not in that locality, problem. Second, this is a major concern for me. I've been saying this forever. I'm sure at least one of your family members must have been a diabetic. Yes? Do they take vitamin B12 tablets? Yes or no? Obviously they will, right? On a daily basis, without reason, we have been pushing B complex. Yes, we've been pushing B complex. Don't substantiate with that saying, I read in pharmacology, metformin causes megaloblastic anemia. Okay, let's assume that is true. The patient is taking metformin. I'm giving B complex. This is not justified at all. The patient takes metformin. This metformin causes megaloblastic anemia. The patient presents symptomatically with anemia. I give them B12. This is the right route. I will not prophylactically give B12. Nothing is given prophylactically unless there is a protocol, right? I have a disease, then I treat it. How do you treat B12 deficiency anemia or how do you treat megaloblastic anemia? This also you guys know. What's the treatment modality for megaloblastic anemia? We give injections, right? How many injections do we give? Do we treat the patients forever, like 1 year or 2 years, or we give four or five injections? we give limited injections, right? Even if the patient is completely deficient of megaloblastic anemia of B12, we give 5 or 6 injections on a regular basis, one shot and maybe 4 to 5 on a follow-up basis. That's all. And physiology taught you that if I'm going to give 4 or 5 injections for a person, how long the store will last? For how long the stores will last for B12? 1-2 months or 1-2 years? It's going to last for years because B12 has an amazing stores, and by 4 to 5 injections we're going to treat the deficiency and we will replenish the stores, right? It's going to stay for years. So B12 abuse, whatever we are doing for our parents is an abuse of B12, not prophylactic treatment. We are abusing B12. If I have a problem, I'm going to treat. See, folic acid has a less store, B12 has a very, very long store. Apart from that, I will keep this ahead. What is the source of B12? For us, what is the source of B12? What is the source of B12? Source of B12 is simple. Food which is rich in liver, like meat of any of those conditions. Milk is one of the source of B12 because milk has bacteria, and most importantly, can a gut bacteria synthesize B12? Yes or no? A gut bacteria can synthesize B12, right? So B12 for us sources, one major source is meat, whatever meat you said. The other major source is going to be milk. Milk will not give B12, but milk will have commensal bacteria that can give B12, right? Okay, that can give B12, and also our perfectly normal bacteria in our microbiome. So all Indian persons will have bacteria in their body, colonic microflora, yes. So will they synthesize B12? Yes. So the deficiency of B12, they will be either meat eaters. If you are vegetarian, you will consume milk for sure. See, half of the belt of a country lives on paneer. Down if you come, there are more non-vegetarians. Definitely I'll have B12. Whichever part you belong, you will have B12. So again, one more problem is B12 deficiency is again doctored in our country. Right? It's not the real B12 deficiency. Until I'll come to that again later soon, right? The B12 tablets, right? It's again doctored in our country. When I was working for the first time, see, I'm not too inclined towards research. I don't know what happened. Is it clear or is it stuck? For me, it looks like it's stuck. Is it fine? Okay, I'll come to your question, Naga. Okay, what we did was, when I first came out of JIPMA, we did a study that we took the leading brands of machines. Okay, we took the leading brands of machines which does your biochemical analysis. We did B12 for the sample. We took blinded, totally blinded, 100 samples, totally blinded. We did B12 there. And we also know that when you work in your biochemistry labs, we look for everything manually, like Benedict's test. Strip is what we do in practical, but we do manually Benedict's test, sulfosalicylic acid, heat protein, heat shock, all those things we do manually. So same samples we did B12 manually as well. But when you see the difference, almost every sample we did manually had normal B12 values, and close to 40 to 50% of these samples had reduced B12 values. Right? Had reduced B12 values. So that didn't get published at all. We were stopped because you know who rules medicine, right? So there is lots of conspiracy theory. The day I saw this, I didn't have a perfect thesis, perfect research publication not published, because the machines here are little bit abnormal, right? Two things: don't treat a lab value. Lab values are done by automated machines. Automated machines are prepared by multinational companies which runs on profit. That's why I always insist all our students to treat the patient, not the lab data. Let's assume that the patient is having a B12 deficiency. Will the patient have anemia or not? If my bone marrow is not able to proliferate for 1 month, you will have anemia because daily it has to proliferate. If it is symptomatic, treat it. Asymptomatic, watch it. Okay, we'll come to your question. See, B12 deficiency prevalent in India, especially among women. Nagavirudhini, right? The reason why B12 is common is we know that if you are going to have a guy and a lady coming into the hospital, I'm going to give to a lady. See, unfortunately, this is true. Deficient B12. when the data is entered, automatically the value changes, right? B12 might be deficient. I'm not saying it will not be deficient, but yes, if they are symptomatic, I'm going to look for it. If you're not symptomatic, I am never ever in your life, you are never ever going to treat a lab value. You're going to treat the patient. Sure, limbo, progress. Okay, we'll come back to this. So we'll come back to B12 abuse. So which means the daily intake of B12, whatever our parents are giving in the form of medicine, is not required. Someone asked me how many days I can give. Don't even give. If your parents are symptomatic, treat them. It's not indicated. Okay, it's not indicated. The treatment is not indicated. Okay, there is no prophylactic treatment required for your elderly diabetic, elderly hypertensive person, right? Nothing is required. How many of your post interns here? How many of your post interns here? If you're a post intern, one thing you must have commonly noticed, especially if you have worked in a PHC, the amount of rush which comes to a PHC, especially a PHC, for the B12 injection, is it more or less? They'll come to the doctor and ask me, please give me this injection, right? They'll ask that. You must have definitely come through it. Indication? No. See, I had this injection yesterday. I had a symptomatic, I felt good, right? I felt good, that's all. So they want to have it again and again and again. That too parenteral B12, abuse again there, right? Abused again there. And we are nothing doing but abusing, right? You will scold for once or twice. After that, the person will give 10 rupees to the compounder, get the injection and go away. Everywhere, if it's been abused. If you don't believe in me, you can Google articles of B12 abuse in colonic cancer. It will cause colonic cancer, right? Everything is being abused in our country. Okay, B12 abuse is one of the causes of colonic cancer. Okay, it's one of the causes of colonic cancer. Yeah, and we also know, everyone here know, knee pain has nothing to do with B12 deficiency, right? But it's been made like that. It gives a good symptomatic feel, maybe just like a placebo. That's all. Okay, it becomes like that. You'll carefully look at how our things move through. You'll have lots of idea about medicine. The recent recent fanciness has been started saying that I'm a vegan, right? If you look at the en masse, especially the younger community, 20 to 25 years old, they are more gullible for change. Vegan. Foreigners use vegan diet. I'm going to start becoming a vegan. Europeans use vegan diet. I'm going to become a vegan. When you do vegan diet, what will happen to B12? B12 will become nil. Right? B12 will become nil. Right? We have only this source. B12 will become nil. When you follow your one more food fascism is you have your gluten-free diet. I'll have more diseases, right? I'll have more diseases. Again, when an entire population, Virat Kohli is a pseudo-vegan. I'm not going to comment on that. We'll maybe discuss it post-class, right? When my entire population and my celebrities are going to promote veganism, which is being promoted by bigger people for profit, right? For profit, on a long term, I might have some problem. Okay, I might have some problem. So this is about entire thing when we disturb our normal food habits. If you want to stay healthy, listen to your mother. And just listen to your mother. When your mom says eat this, don't ask second question, eat that. A vegan population cannot make up for the B12 loss. They will require injection regularly because they need external supply. They don't have anything internal. They would require B12 injections on a regular basis. That again should stay within 4 to 5 doses. If they keep abusing like our elderly PHC population, again they will have a problem. Okay, so that's what B12 does, right? One of the most important sporadic thing. On top of that, we don't keep our mouth shut. Alcohol, smoking. One more important thing in diet is smoked foods. Okay, smoked foods as well, right? This will add to the burden. That's all. It's not going to do anything. This is just going to add to the burden, right? This will definitely add to the burden. Smoked foods again is an important problem. Yes, everything in gastric carcinoma, every GI carcinoma is going to happen, right? Smoked foods. See, we don't translate our knowledge into practice. That's a huge gap between for us. Ritvik exactly said that smoked fish is the reason why Japanese have lots of gastric carcinoma, right? All of us know that. But all of us here, do we like tandoori foods? Yes, all of us here like tandoori foods. We know that theoretically, an important MCQ, Japanese got gastric carcinoma because of eating smoked foods. But we love tandoori foods. What is tandoori? Tandoori is smoked. We like tandoori naan. It's smoked, and everyone loves that. And it's smoked. See, there's a problem: knowledge and application. If the problem is sorted, most of our worries will be sorted, right? Grilled is again a problem, but it will not be a problem for our country. I'll tell why. When do you eat tandoori foods? Do you go and buy tandoori foods, or if it's your friend's treat, you go and order tandoori chicken or tandoori, whatever it is? We generally order whenever if it's some bakra coming and if it's some friends. We use it occasionally. We don't have tandoor in our homes. Most of the places at least don't have tandoor in our homes. We don't have grill in our homes. Whenever it is free, we go and binge eat. We have it occasionally. So as of now, this guy is not a problem for our country. Again, when the habit creeps in, they start to sell they start to sell barbecues in your home. Go and cook in your home. That time, yes, I'm worried. This is a tiny little country. The population of Japan may be like the population of Mumbai. That's all. If smoked foods can cause so much gastric cancer in Japan with this tiny little population, if it becomes a habit for us, we are looking at a very, very sad stage in future, right? So try to avoid tandoor foods. Once in 2 months, fine. Not regularly. It is definitely going to affect us, fine. These are few acquired causes, okay? Acquired and your inherited causes. I'll just touch on one more topic. See, this session is especially to understand the pathogenesis rather than giving you more and more tips, right? If you look at colon cancers, inherited guys of colon cancers, I have two major things, like you guys said, familial adenomatous polyposis and HNPCC, right? I have two guys, familial adenomatous polyposis and HNPCC. Again, if you have read colon cancers, there are few variations in colon cancers based on the site of involvement. We have something called as a right-sided colon cancer and we have something called as a left-sided colon cancer. I'm sure you guys know that, right? These are two inherited things. We'll keep it aside. FAP is going to help in the cell proliferation, right? It helps in cell proliferation. I'm sure you guys know how an FAP acts, sorry, how an APC acts, not FAP, how an APC acts, right? How an APC acts is when growth factor comes, APC will release beta-catenin. Beta-catenin will help in cell proliferation. That's the role. So I'm just simplified in writing. It helps in cell proliferation via your WNT pathway. Perfect, right? What does HNPCC do is, we have mutations in these genes, right? MSH1, MSH2, your PMS1, right? PMS2 and all those things. What is the use of these genes? What are the use? They help in the repair mechanism, right? One helps in the proliferation, one helps in, to be specific, they are part and parcel of mismatch repair mechanism. Okay? Part and parcel of mismatch repair mechanism. If you remember your biochemistry again, you will have a cell cycle. In the cell cycle pathway, what it says is, initially at the S phase, synthetic phase, I can have few errors which will be corrected by few repair mechanisms. Post-synthetic phase, at the G2M transition, I'll have few more errors which will be corrected predominantly by mismatch repair mechanism. So which means when a cell divides, automatically we will have DNA defects or mutations, yes or no? With the presence of carcinogen or without the presence of carcinogen, when a cell divides, there are errors which are bound to happen. That's why we have so many repair mechanisms which acts exactly on the cell cycle, right? So this is going to correct the repairs not on exposure to carcinogen in a normal cell cycle. Okay. Correct repairs in a normal cell cycle. Okay, fine. Now let's go into our physiology and anatomy. I have right side colon and I have left side colon. What will be the left side colon? This is my left. My left side colon is going to be a descending colon, sigmoid colon, rectum, right? That's the major of the left side colon. Right side colon, ascending colon, and maybe half of your transverse colon, right? That's your right side colon. What is the function of a right side colon? What's the function of a right side colon? Function of a right side colon? It is going to help in more of absorption. Function of left side colon? Function of left side colon? It's going to make sure the stool becomes desiccated, and it's going to make sure the stool goes outside properly. The majority function of the right side colon is absorption. This again we know, I'm just writing in the corner. The right side colon is going to help in absorption. The left side colon is going to help in your formation of stool, right? Stool formation. Okay, it's going to help in your stool formation. We'll keep this here. Okay, we'll keep this side. So now tell me, I have two different functions for two different colons. Which of these two colons will require more cell turnover? I'm having two different things. Which of these two colons will require, will need actually more cell turnover? Right side or left side? Right side, right? Have more absorption, so there must be more cell turnover. Because absorption, nothing means they are microvilli. Whenever you have a microvilli, automatically we know that you are going to end up in your villi are very, very fine things, microvilli. They will die, so it will require more damage will be there. So I need more repair, there will be more cell cycle. Here, there will be obviously recycling happening left side also, but I'm just conservatively rating, not that much. When compared to right, not that much. Now tell me, which of these two guys will require your MSH, MLH more? Which of these two guys are more dependent on them? Right or left? Obviously the answer is right, right? I have more damage, I have more recycling, I require more of MSH, MLH. So when I have mutation in any of them, so HNPCC, where will you have the colon? So where will you have the cancer? Right side or left side? Right side. It's not a fact, it has a reason, right? We are going to go for the reason only, right? There's a reason and we are going to primarily go for the reason only. So you have your right side colon cancer and we have left side colon cancer. I'll put a disclaimer here. That doesn't mean that left side colon cancer will never have HNPCC mutation. It will, it might. Again, we are going to go on base of incidence, that's all. Right side more, right? They'll have more dependent on your repair mechanism or your mismatch repair mechanism. Here they're less dependent on it, okay? They're not exclusive, nothing else is exclusive in our body, both can occur, right? They're less dependent. So obviously, something related to HNPCC will be more common on the right side, something related to FAP or your APC beta catenin will be more common on the left side. Again, these are statistics, that's all. For statistics will be backed up by science, always it will be backed up by science. Because statistic means you have to have a significant value, right? Your p-value should be significant, then only it comes true, okay? So I have right side and left side colon cancer. Do you know any other findings of right side and left side colon cancer when you look at the microscopy? Again, we'll go to that only. Let's assume that normally your colon has villi, right? Normally also your colon has villi. Let's assume it's like this. This are my villus epithelium. Normally also my colon has villi. Let's assume that when this villi dies, okay, when this villi dies, I'm just zooming it up. I'll shade in different colors because everything is based on pathogenesis. One with pink, one with blue, one with yellow, right? So let's assume that these three villus cells are going to die. Possible, right? Whenever the three villus cells dies, will they be regenerated? Yes, right? Let's assume that for the first time, when there's a regeneration, because of the mismatch repair, the pink villus cell, the epithelium, didn't regenerate properly, right? When they didn't regenerate properly, what I will have is, I will have a abnormal growth here, right? The next time, after a few months or years, the blue thing didn't regenerate properly, right? So I'm having an abnormality here. Then my yellow thing didn't regenerate properly, right? Like that, it will not happen at the same time, because the mistakes don't happen at the same time. Mistakes happen in a different times. So when I look at this, if this pathogen is right, if this basic common sense of us is right, we're going to extrapolate it as the tumor will be like this. It will be a villus, but it will look like this. How does it look? It looks like Ritvik said, it looks like a serrated polyp. Right? It looks like serrated polyp. This is very important for me. When a pathologist looks at a serrated polyp in microscopy, I can confidently sell its HNPC for the one. These guys will be tubular, your villus, and others. Is it fine? Yeah, I hope it's fine. Okay, these guys will be tubular, villus, and others, just for our namesake. But this you have to remember, when you have serrated problem, think of an mismatch repair mechanism, HNPCC. Okay, next. Here they have more of T cell infiltration. That's understood, right? That's understood. I am having a cell with a defective mismatch repair. So obviously my body will first try to remove that cell and throw that cell away, right? Remove and throw that cell away. So it has more T cell infiltration. Okay? This will have less or nil T cell infiltration. Again, we are going to link everything to the pathogenesis, which means these are highly immunogenic. Right? These are not. Okay. We know two things in the pathogenesis: the mismatch repair mechanism and the amount of T cells. Pathogenesis should reflect to prognosis. If it is not reflecting to prognosis or patient management, I will not be required in the patient management system at all. I had to tell this each and everything to the surgeon. The surgeon, not mainly the surgeon, the medical oncologist. The medical oncologist should understand this. I'm going to say they are highly immunogenic. I'm having a cancer here. Let's assume I'm having a cancer here and lots of T cells here. The T cells are not working because this cancer has evaded the immunity. Can I make this T cells destroy this guy? Possible? Yes? What drug? Immunotherapy. Good. So these are all T cells which are already there, which are not able to destroy for the only reason it's been there. So what is required is, when I say it's a mismatch repair, I talked about this in your gastric cancer with Dr. Saurabh Dikshit, right? I'm going to do a PD1, PDL1, and I can use an immunotherapy. Treatment modality. First is immunotherapy. I'm going to think of an immunotherapy almost always. They might work because the microscopy will have lymphocytes which are not doing its job. By immunotherapy, I'll make them, it will do the job. Second, I'm having a cell with a defective mutation. Right? The defective mutation. Is it easy to kill a cell with a mutation, or is it difficult to kill a cell with a mutation? Or in other words, a cell with a mutation like mismatch repair, is it stable or unstable? It will be unstable, right? So when I have an unstable cell, can I give chemotherapy and work on that? Yes, I can give chemotherapy. They will be chemosensitive. Again, very important. When a surgeon gives me a biopsy, he is looking for this. He is not looking for adenocarcinoma. That he knows. The patient saying the complaint and looking at colonoscopy, there's a growth. He will know it's an adenocarcinoma. Why he is taking a biopsy to me is not to give it's an adenocarcinoma. I'm going to say, see, this person has more lymphocytes. So probably, I am not 100%, probably this is a mismatch repair related pathogenesis. So give chemotherapy, because if you remember your colon cancer protocol in surgery, it will be neoadjuvant chemotherapy, reduce the size of the tumor, then go for a surgery, right? If it is this type, no inflammatory cells, and most of the APC beta catenin will have KRAS mutation. KRAS is an intrinsic component, right? Will KRAS mutation respond to traditional chemotherapy? KRAS is like thug life. Whatever you give, I will not be worried at all. KRAS will not respond to chemotherapy. These are chemo-resistant. Okay, these are going to be chemo-resistant, right? And immunotherapy might not work. No immunotherapy as well. So the only option left is upfront surgery. See, this is my role as a pathologist. When a surgeon gives me a biopsy, I'm going to say that I will tell to the surgeon and the medical oncologist, see, this cancer chemotherapy will not work. because this type of tumor by nature will be chemo resistant, but I will leave it to the surgeon or the medical oncologist to take a decision. The surgeon and medical oncologist should not take the decision, should give that decision to the patient. You have to wait. Every onco consultation at least requires 30 minutes to an hour. You have to explain everything to the patient. See, I can give chemotherapy, because they will ask questions that some friend of theirs had chemotherapy and the tumor became smaller, because they will phone and call everyone and ask when they have a cancer. They are afraid. Role as a doctor is, see, this is how the disease is. I can give chemotherapy for your this type of tumor. It might not work. You have to tell this to the patient, because chemo, one is expense, second is side effects. The patient is going to go through a hell lot of side effects for a tumor which is not going to respond. Tell them, see, we'll go for an upfront surgery. Unfortunately, you have a tumor which is not going to be resistant. On the other hand, if it's this type, you have to insist this will be extremely chemo responsive. So if I have T3 lesion, give chemo, it might become T2, it might even become T1. It's good for you guys, right? That's the role of a surgeon or a medical oncologist, backed up by surgical pathology, right? That's so much things about to learn in the neoplasm of colon, right? You just gone through this very superficial bit of it for us for a better understanding. So next time you read surgery or medical oncology or medicine or pathology, I want you to read all these things, right? Because these are the base. With this base, the amount of mark you will score with this learning will be the same. I am not here for your scoring marks. The amount of clarity you will get to a topic and the interest you will develop a topic will be more. That is our ultimate goal. We are going to read more, we are going to understand the disease better, and we are going to have a perfect management. When everything falls in line, you will not feel like a burden. I know this, it goes like that. Fine. Okay. Thank you for your time. Must have been an exhaustive topic, but total thing covered will be very less, but you will never forget all of these if you are able to find the link. Okay. Thank you. See you soon by 8 o'clock with the GI quiz. See you. Bye-bye. Thank you guys.